Investigations for sinus node dysfunction. Autonomic testing. Carotid sinus massage. In normal persons, carotid sinus massage decreases the sinus node rate, but does not precipitate sinus pauses. In carotid sinus syndrome, CSS, massage of one carotid sinus at a time for 5 seconds precipitates a pause greater than or equal to 3 seconds, associated with blood pressure, BP, drop greater than or equal to 50 mmHg. Carotid sinus syndrome is usually due to sinus node dysfunction. In old age, CSS may be the only manifestation of sinus node dysfunction in otherwise asymptomatic individuals. Effects of carotid sinus massage. Carotid sinus massage results in vagal stimulation and sympathetic withdrawal with depression of sinus node automaticity, slowing the heart rate. Depression of AV node conductivity, prolonging the PR interval. Prolongation of action potential duration. Prolongation of refractory periods. Tilt table test. The tilt table test is a form of orthostatic stress test, to assess the susceptibility for a vasovagal response to a postural change, from a supine to an upright position. A positive test may indicate autonomic dysfunction causing extrinsic sinus node dysfunction, but it does not indicate intrinsic sinus node dysfunction. Excessive vagal tone is a known cause of extrinsic sinus node dysfunction, for example, in carotid sinus syndrome, neurocardiogenic syncope, and in well-trained athletes. Diagnostic yield of tilt table test. Unfortunately, the diagnostic yield of this test is generally unsatisfactory. Positive response is classified into 2 types. 1. Cardio-inhibitory response, heart rate less than 40 beats per minute, for more than 10 seconds, or asystole longer than 3 seconds. 2. Vasodepressor response, blood pressure drop that causes syncope, with less than 10% drop in heart rate. Procedure of tilt table test. Patient is placed on table in supine position and connected to monitor, then tilted upright to an angle of 60 to 80, usually 70 degrees, for 30 to 45 minutes. If no pulse or blood pressure abnormality is detected, isoproterenol bolus is used. Indications for tilt table test. 1. Recurrent syncope, suspected to be vasovagal, while the clinical presentation is atypical, and after exclusion of structural heart disease. 2. Single syncopal episode, resulting in injury or occurring in a high-risk setting. Contraindications to tilt table test. 1. Significant atherosclerotic disease, coronary or cerebral. 2. Ventricular outflow obstruction, at the aortic or the pulmonary valves, or at the left or right ventricular outflow tracts. Pharmacologic testing. Total autonomic blockade. Total autonomic blockade, to uncover the intrinsic sinus node rate devoid of autonomic modulation, is achieved by using intravenous atropine 0.04 mg per kg, for parasympathetic blockade, plus intravenous propranolol 0.2 mg per kg for sympathetic blockade. Sinus node dysfunction is diagnosed when the intrinsic heart rate is less than the predicted rate, using the following formula. Intrinsic rate equals 118.1 minus 0.57 times age in years. Interpretation of intrinsic HR. A low intrinsic heart rate is consistent with intrinsic sinus node dysfunction. A normal intrinsic heart rate in a patient with known sinus node dysfunction suggests extrinsic sinus node dysfunction. Atropine alone, 0.04 mg per kg, in subjects with healthy sinus node, should result in increase in sinus node firing rate, decrease in sinus node recovery time, corrected sinus node recovery time, and sinoatrial conduction time. The following is diagnostic of impaired sinus node automaticity. Failure of atropine to increase the heart rate above the predicted intrinsic rate. Persistence of junctional rhythm on cessation of pacing. Propranolol alone, 0.1 mg per kg, should result in decreased sinus node rate in normal subjects and in patients with sinus node dysfunction, suggesting that sympathetic responsiveness is intact in most patients with sinus node dysfunction. Increased sinus node recovery time, and sinoatrial conduction time, in most patients with sinus node dysfunction. Isoproterenol. Isoproterenol increases sinus rate of at least 25% in normal subjects. An impaired response occurs in some patients with sinus node dysfunction. Digoxin. Digoxin shortens sinus node recovery time in some patients with clinical sinus node dysfunction, probably because of increased perinodal tissue refractoriness, with consequent sinus node entrance block, thus reducing sinus node suppression by pacing. Antiarrhythmic agents. Procainamide, quinidine, maxillatine, and amiodarone can cause adverse effects such as sinus bradycardia and sinus pauses, in patients with sinus node dysfunction. Electrophysiological studies, EPS. EPS for sinus node dysfunction, discussed earlier, are indicated in symptomatic patients, in whom sinus node dysfunction is suspected but cannot be documented in association with symptoms. Besides sinus node dysfunction, EPS help evaluate other types of arrhythmia, as potential causes of syncope and palpitations. Limitations of sinus node recovery time, SNRT. Many factors in addition to automaticity are involved in the measurement of this time, including conduction time from the pacing site to the sinus node and vice versa. Sinus node entrance block during rapid atrial pacing, which can protect the sinus node and shorten the time. Sinus node exit block after cessation of pacing, which can prolong the time. Sometimes, this time cannot be measured because of atrial ectopic or junctional escape beats that precede the return sinus beat. Despite all these limitations, and because no better tests are available, sinus node recovery time is the most widely used test for sinus node automaticity. To improve the sensitivity and specificity, multiple measurements at different pacing rates are advisable. Sinoatrial conduction time indirect measurement assumes that the sinus node automaticity is not affected by atrial pacing, conduction times in and out of the sinus node are equal, and no shift in the sinus node pacemaker site. Direct recording of the sinus node electrogram may be obtained, using high-gain unfiltered electrograms, in approximately 50% of patients. The catheter is placed near to the sinus node. Recording reveals the sinus node potential, SNP, followed by the A wave. The sinoatrial conduction time is the interval between the onset of the SNP and the A wave. Prolonged time may indicate sinus node dysfunction. In SA block, a sinus node deflection, not followed by an A wave, may be recorded. The time zones of response of the sinus node to atrial extrastimuli, AES, may now be discussed in some detail. 4 zones have been identified: collision, reset, interpolation, and sinus echoes. The sinoatrial conduction time can only be measured in the zone of reset. The zone of collision is defined by the range of coupling intervals, CI, at which the return interval, RI, or the pause after the AES, is compensatory, that is the CI plus RI equals 2 cycle lengths, CL. A late AES collides with the spontaneous sinus impulse, the sinus pacemaker and the subsequent sinus beat are unaffected by the AES, that is, a compensatory pause is recorded. In our example, CL is 660 millisecond, CI 590, RI 730, CI plus RI equals 1320, exactly equal to 2 CL. The zone of reset is defined by the range of CI at which reset of the sinus pacemaker occurs, resulting in a less than compensatory pause. An earlier AES results in penetration of the sinus node with resetting, so that the resulting pause is less than compensatory, but without changing sinus node automaticity. In our example, CL is 660 millisecond, CI 530, RI 760, CI plus RI equals 1290, which is less than 2 CL. The zone of reset typically occupies a long duration of the cycle length, CL. In most patients, the pause remains constant throughout the zone of reset, producing a plateau in the curve, indicating that the sinus pacemaker automaticity is not affected. Clinical application of sinoatrial conduction time. Despite some limitations, the Strauss indirect method of measurement is a reasonable estimate of sinoatrial conduction time, provided that stimulation is performed as closely as possible to the sinus node, and measurement is taken when a true plateau is present in the zone of reset. The zone of interpolation is earlier in the CL than the zone of reset, and is defined as the range of CI at which the return interval, RI, is less than the sinus CL, and the sum of CI and RI less than 2 CL. In our example, CL is 660 millisecond, CI 330, RI 630, which is less than CL, and CI plus RI equals 960, which is less than 2 CL. The zone of sinus echoes is the earliest zone in the CL, and is defined as the range of CI at which the sum of the CI and return cycle less than or equal to 1 CL, and the P-wave morphology and atrial activation sequence are identical to the sinus beats. In our example, CL is 660 millisecond, CI 260, RI 400, and CI plus RI equals 660, equal to 1 CL. Thank you.